So welcome to the third annual edition of the Unacceptables at Health 2.0. For those of you who are attending this session for the first time, this is a really special opportunity to shine the light on disparities that we really shouldn't tolerate because we have the know-how, we have the means to do something about them. In the past 2 years on this panel, we've highlighted a range of issues, from the opioid epidemic to addiction in general, physician burnout and suicide, eating disorders, natural disasters, loneliness, violence, diversity in tech, the digital divide, addiction in general, as mentioned before, and also organ trafficking. So this is not a lightweight session. We really are looking at big, intractable issues. But again, the important thing is to know that there are entrepreneurs out there doing something about it and using technology in some way to enable those solutions. So this year's Spotlight Issues, we decided to look at homelessness, maternal mortality, and human trafficking. And we're going to hear from both experts who are going to set the stage for us in each issue area to tell us what is the world we're entering here, and then look at specific initiatives and solutions that are being trialed to make a difference. So just to reiterate, the inspiration for this panel really came from this quote by Tony Robbins, which is, "We get what we tolerate." And so the unacceptables are disparities that we have the means and know how to fix, and that's what makes them unacceptable. So I hope that today this panel inspires you to tackle the biggest issues you can think of in health and healthcare, and that we have a lot to learn from these folks to spread the work that they're doing. So with that, I would like to showcase a few of the startling statistics in the areas that we are looking at this year, and to sort of tell you why we chose them as our spotlight issues. So over 552,000 people experienced homelessness on a single night in 2018. 33% of those folks are families with children. And in LA, where I'm from, despite $1.2 billion of taxpayer money that we allocated for it, homelessness jumped 12% since 2018, and this was really sort of a dismaying statistic. On the issue of maternal mortality, for those of us that have been following this, a lot has been written about it, but every time I sort of look at the statistics, it's just eye-opening. We're the only developed country with a rising mortality rate in this area, doubling from 1991 to 2016. African American women are 243% more likely to die in pregnancy or childbirth-related causes, and 33% of Black women say that they have been discriminated against when visiting their doctor. Human trafficking came to my attention. I've been hearing about it in the news, in the media, but I got to meet one of the experts on the stage today at a fellowship that we're both in, and I've learned so much from how this impacts the health system. 25 million people are trafficked worldwide, but in the United States, there are reports in every single state, even though the total number is still elusive to us. 34% are involved in forced labor, 59% in sexual exploitation. And since 2007, nearly 49,000 cases have been reported to the national hotline, a 13% increase in 2016. And we're going to be talking about the impact this has on the healthcare community and what we can do about it. So that's what we'll be tackling, and I want to waste no time getting to our first presenter. And we're going to tackle the subject of homelessness. So I'd like to invite Tim Mercer to the podium. And as he comes on, I'm going to introduce him and tell you a little bit more about him. Very good, Tim. Thank you. Okay. And I'm going to take a seat and then chat with Tim when he comes back. So Tim is the Director of Global Health at Dell Medical School and an assistant professor in the departments of Population Health and Internal Medicine. He's a primary care physician for Austin's Healthcare for the Homeless program and is interested in solving health system challenges to improve access, quality, and equity in health for vulnerable populations globally. Today he's here to share some of the current trends and data in the homeless population, as well as set the stage for the issues in the community surrounding identity documentation management.
Thank you very much, everyone. Thank you so much for having me here and for attending this really important session. So as mentioned, my name is Tim Mercer. I'm faculty in the Department of Population Health at UT Austin Dell Medical School and a primary care physician in the Healthcare for the Homeless program at Community Care, which is Austin's largest community health center network. I'm going to set the stage for y'all with a brief overview of homelessness and the issues, the healthcare issues this population faces, and then discuss the central role of identity and information and systems integration in one's ability to access services and receive high-quality care. I received some grant support from NIH, SAMHSA, UT, but have no conflicts of interest to disclose. So there are over 500,000 people experiencing homelessness in this country. On any given night, about 130,000 here in California, about 25,000 in my state of Texas. And what's concerning is that despite our booming economy, record low unemployment rates, these numbers are rising. If you look at both California and Texas, and you'll see over the last just 3 to 4 years that the total number of individuals experiencing homelessness is on the rise, as indicated by the dark blue line at the top, and the numbers who are unsheltered, meaning literally sleeping out on the streets under the bridges, is also rising. In my hometown of Austin, just since 2015, the number has risen from about 7,000 to 8,000, although we know most homeless number estimates are underreported. And again, most concerning is the percentage of people who are chronically homeless, meaning continuously homeless for an entire year, has more than doubled in just these 3 years, from 22 to 54%. The drivers or causes of homelessness are complex and multifactorial and almost never a lifestyle choice. More proximal drivers relate to poverty and economic displacement, mental health and substance use disorders, and cohabitation instability or loss of family or social support networks. Trauma of many forms underlies much of this, and it's something I hear over and over again in often harrowing stories from my patients. For example, domestic and family violence is the leading cause of homelessness for women and their children. And we can't talk about homelessness in this country without talking about race. In every single state in this country, African Americans are more likely to experience homelessness than whites, sometimes 10 times more likely, as shown by the states in red. And this cannot be explained by socioeconomic status or education levels alone. This is a result of systemic or structural racial inequities in our healthcare, criminal justice, and housing policies and systems. This population is very sick and medically complex. I spend half my time seeing patients, all of whom who are experiencing homelessness, and it is a very sick and complex population. Across the board, the homeless population has, compared to the general population, has higher rates of mental health disorders and substance use disorders, higher rates of infectious diseases like tuberculosis, HIV, and hepatitis C, and higher rates of chronic diseases like hypertension, diabetes, and cardiovascular disease. And importantly, these conditions are almost always much more poorly controlled and present at later stages compared to the general population. Because of all this, homelessness is frankly deadly. For those of you in the audience over the age of 53, I won't ask you to raise your hand. If you're homeless and sleeping on the street, you would likely be dead by now. 53 is the average life expectancy for those who are homeless and unsheltered. If you have HIV, diabetes, even breast cancer, you are still likely to live longer than if you are homeless. So let me switch gears and tell you a story about one of my patients. He was homeless and a few months ago moved to Austin from Louisiana to try out his new life there. Since landing in Austin, he'd been hospitalized once for his chronic lung disease. And then a few weeks after that, one night out on the street, like so many of my patients, his backpack was stolen. And in that backpack was everything he had, including his medications and his ID. He lost his identity, and just like that, he became a nameless face or a ghost in our system. He spent weeks trying to gather out-of-state documents and prove to the authorities who he was so he could get an ID and then access medical and social services. In my clinic, he tells me this story and tells me about his hospitalization and his previous medical care in Louisiana, and he kind of offhandedly but very logically makes the comment, well, you can look all that up in the system, right? And I literally laughed at him and then gained my composure because he was not laughing and he was totally serious, bewildered that I could not do this in this day and age. So then we had to do totally ridiculous things like sign paper ROIs and send faxes that are inefficient and archaic to try to get this information. I then went on to explain the various services that were available and made referrals, but of course, he'd need an ID first. So identity, such a fundamental issue to access healthcare at a clinic, pick up medicines at a pharmacy, get other social services. You and I keep our ID cards in our wallets, passports, birth certificates in our safes at home, backup copies and everything scanned into our computer. Can we get the slides up? Sorry. Into our computers. But for my patients, getting their backpack stolen or their documents soaked in the rain and their identity is gone overnight. And if that's not enough, they have to operate in this fragmented care system where we don't share information, and their identities exist in these siloed systems that are not shared. This is the dozen or so well-intentioned organizations and healthcare agencies, social service agencies in Austin that are providing services to the homeless, none of whom really talk to each other or share information. So how do we move to a system that puts our patients at the center and where our patients' identities can't be stolen with a backpack or dissolved with a heavy rain, and where our care providers and institutions can share information to provide more holistic patient-centered care? The author E.M. Forrester wrote, "We are not concerned with the very poor. They are unthinkable or unacceptable, and only to be approached by the statistician or the poet." So thank you for being here today, thinking collectively of how we can apply technology and our collective human capital to give these people their identity back and solve these problems. Thank you very much.
Thank you. So Tim, I'm actually going to bring Anjum up, and then we're going to chat we'll talk to you about your presentation as well. So Tim really set up that issue of identity management and establishing that identity, and now we're going to present to you Anjum Khurshid. He is a fellow at Dell Medical School, a fellow colleague of Tim's at Dell Medical School. He's the director of data integration in Dell's Department of Population Health. In 2014, he was appointed to the Federal Advisory Committee on Health Information Technology Policy, and in 2016, he was also appointed co-chair of the Task Force on Interoperability Experience formed by the Office of the National Coordinator. His latest work in Austin is a pilot project that's testing how blockchain technology can help people experiencing homelessness access and manage their medical records and other documents. Welcome, Anjum.
Okay. Well, good afternoon, and thank you for being here. I'm very excited to be sharing with you some of the work that we are doing. So from Tim's presentation, there are like 3 issues that come up that need to be solved if we are just managing identity for the homeless. One is just managing, the proof of identity, whether it's a driver's license or anything else. The second is consent, because once you share their identity, then there are also concerns about privacy, confidentiality. And the third is what we describe as interoperability, meaning agencies to be able to share data with each other. And all 3 are big barriers in terms of providing a more system-level support to the people who are experiencing homelessness. So the example that I will show you, before I show you the demonstration, I wanted to explain at least the use case that goes behind it, because you might not see all that in the front end. But really think of a patient, any patient, and in this case it's a homeless patient, Alice, who walks into a clinic, and let the clinic be called the Texas Clinic. And she uses her phone to scan the QR code or identify that she's checking in. The clinic basically looks at the government-issued ID and then enters the profile or the credentials in their record. So this is the clinic's system. And then sends that record back to Alice so that she can confirm that it is accurate. And once Alice confirms that, then she has now a validated identity on her wallet, which is on her mobile phone, which has been validated by the clinic because the clinic has actually validated her credentials against a government-issued ID. This is a process that happens in almost every clinic when you go there. You have to show your ID, you get your information entered into a system within the clinic. What is different is, and what we wanted to address here, is when she goes to the next clinic. So let's call that Clinic Health 2.0. It may be in California, in Texas, or wherever in the US. Alice walks in, again, checks in with a QR code or whatever, and then basically shares her validated profile with the second clinic, which gives her name, address, etc. And sends that information to the clinic, which now sees that Alice has checked in. And then, but that clinic needs to verify that with a third party. Now, usually they would see an ID card, which is a government-issued ID card. But in this case, because her identity has already been validated by another clinic, and cryptographically, if the second clinic connects with the first clinic, then they have a validation from another clinic that has already seen the government-issued ID. And once they verify that through the blockchain network, because blockchain network, one of the characteristics of the blockchain technology is the immutability of the records. That means cannot be changed easily. So that verifies then for the second clinic that this is the profile and it has been validated by thing. So now we'll switch to the demo and we can show you. So what I've done is that I'm putting two screens on either side. There's usually two devices. One is the computer of the clinic, and the other is the mobile phone of the patient. So if we go to, this is the first clinic. So the clinic is called Texas, and we log in. And you see that they have done the first part, which is they have seen a government ID, they have validated what the name is, what the other credentials as well, phone, email, etc. And now, let's go to the second clinic. So now Alice goes to Health 2.0 clinic, and she checks in with a QR code. So basically says, okay, I'm here to check in. So you see what the clinic is seeing now is that someone named Alice Smith wants to check in. They have no other information from Alice Smith yet. So now it's up to Alice. So now we move to the mobile phone of Alice, and so Alice sees now that she has an identity for the clinic, so that is validated on the network as well. And she goes to her profile because she wants to share her profile. As you see, there are other information as well, like insurance information or medical information, but let's go with the profile information, which, because she has all these data elements, so another thing which does not happen in healthcare today, we usually give our consent as a full consent or no consent, so it's yes and no for all the information. But this allows her to choose which information she wants to share and which she doesn't. So for instance, if she does not want to share her birth date, but you also see that it also identifies on her wallet that the profile information has been validated by Texas Clinic. So when she says share, it asks her which entity she wants to share it. So she shares it with Health 2.0. That information now has been sent to the clinic. So now the clinic, when they check in, this information is going to get the information from Alice's wallet and fill it in. So now she has her email address, phone address, other kinds of things. But this is still coming directly from Alice's device. It still needs verification from a third party. So this clinic will then send a message on the blockchain that actually validates this with Texas Clinic, which is the validator of this information, and that gets cryptographically validated. So as you see, it has now checked into a verified stage. The key over here is that, again, Alice did not have to take her driver's license to the second clinic. She also the second clinic had a way of validating it, and the more transactions happen, the stronger the record becomes. There are also ways where that becomes a self-sovereign identity where the system itself kind of identifies this. And then it's not just her profile. She can choose to share other kinds of information with different partners. And so that's kind of the prototype that we are developing in Austin. We have more details in terms of interacting with the homeless population and other agencies, but we wanted to share at least where we are today.
Much. Okay, wonderful. So just time for a quick question here. One of the things that I asked Anjum, is like, well, what's the sort of percentage of folks with a phone? And you were sharing some really startling statistics with me.
So that is obviously the first question that came up is technology a barrier in terms of accessing this? And we did last year, as part of an initiative piloting with the mayor's office and the city of Austin, we engaged a lot of people who were experiencing homelessness. And what we were surprised by is that the cell phone is probably the most important asset that they maintain. Their bags get stolen, their identities get stolen, but that is the only way that they connect with each other, and also they connect with agencies. So there are studies that have shown this consistently, that more than 70% of homeless, there is another study that was done in LA which showed that 8 out of 11 homeless people who are accessing the emergency department had a mobile phone. So the adoption of mobile technology is pretty high. And then we had also considered, using public libraries, et cetera, because it's not just a mobile platform, it's also a web-based platform. And we've also seen in Medicaid populations where the use of mobile technology is pretty high. So from our perspective, I think it is a technology that is increasingly being used by this population, and this population really is pretty sophisticated in terms of making sure that they have communication devices that can be used for this purpose.
Great. And just a quick word from you, Tim. Your vision for that sort of person-centered care across the community, how does technology like this enable those very disparate services to kind of collaborate and work together more? Because I'm sure that's a big challenge.
Yeah, I mean, the identity validation piece that is one of the things that this technology could solve. But I think more broadly, which I know many of you are working on, is the interoperability piece. I see patients in my clinic, and sometimes, I literally feel like I'm sitting in a silo that doesn't have access to other agencies and services. And my patients, as you heard from my story, expect us in 2019 to be able to look up those records of his from Louisiana, or even especially the hospital down the street, or the mental health care provider, or the other social service agencies. So using technology as a tool to solve the interoperability issue, I think is going to be huge.
Well, thank you both for sharing your pilot work with us, and we look forward to following up. Thank you so much.
Thank you.
Thank you.
Okay. So we now shift gears to look at this issue of disparities in maternal mortality. And I'd like to introduce our first speaker to the podium, Dr. Joia Crear-Perry. There she is. Come on out. She's the founder and president of the National Birth Equity Collaborative. She's a physician, advocate, and policy expert on the role of racism and health equity. You've worked with the United Nations Office of the High Commissioner for Human Rights to improve the human rights framework to improve maternal mortality, and she's here today to help us set the stage for the topic and how NBEC is creating solutions to optimize Black maternal and infant health. Thank you, Joia. Thank you so much.
All right, this is so fancy. Hello, Hims. How are y'all doing today?
Good.
Y'all are pretty quiet. I need y'all to line. I'm from New Orleans. I heard a whole Louisiana panel before, so I need some activity, some call and response. Okay, let's see. So we're going to talk a little bit about maternal mortality. You've probably seen it in the media quite a bit. Our organization is about almost 5 years old, and really our goal and our desire is to see Black mothers and babies thrive. We don't want folks to just survive childbirth and say, woo, thank God I made it out of that, right? Like, that's not the goal. The goal is for folks to thrive. And so it's important for you all, especially in technology, we need y'all to help us to do that, right? It's important to think about what could that look like, because the truth is, sometimes you can use technology and then it causes things to become more disparate, right? If you're not intentional about what you're doing or producing, you can make things worse. So we know, you've probably seen this data, and if you haven't, great. I feel like I say these same slides quite a bit, but so if this is news to you, Black women are dying in childbirth in the United States at 3 to 4 times the rate of their white counterparts. And the United States is the only nation, and only industrialized nation, where our numbers are going up, right? So you see all the other countries are going down, our numbers are going up. And you see that these numbers are going up despite the fact that we spend more money, right? Our GDP, we spend more money on healthcare than any of the other countries who have better outcomes and whose outcomes are getting better, right? And so you have to ask yourself, well, what is that? We're throwing money at it. You know, we love things and buying tools, and yet we're going backwards. If you think about the countries that have a human rights framework, who believe that all people should be able to live to their full potential, they actually have better outcomes. So it's not that they found a gene or a tool, they just actually invest in people. It's a novel idea, right? So they have things like, I don't know, free childcare. I don't know if any moms are out there, but I would have loved that I have to pay for daycare, because that was a lot of money, right? They have things like free college, right? So those places where we build infrastructure for human beings, they have better maternal health outcomes. And so it's important for us to think about, well, how does that play? What does that mean when it comes to equity? When you're doing your work inside of technology, are you thinking about the people who are the most marginalized? And when we created our organization, we had to think about, what does birth equity mean? Like, it sounds like people love making up acronyms and names. And really, it's putting the policies, the assurances, big P and little p, in place to ensure that people have everything that they need to thrive during pregnancy, right? So you have to be willing to address both racial and social inequalities in a sustained effort. So I love my funders, I love the foundations, I heard some foundation names here earlier, but a 2-year grant is not gonna fix it, right? It took us 400 years to get here, it's gonna take a minute. It's gonna take a while for us to undo all the inequalities that we have. So I live in the world of science, I'm an OBGYN. I'm a dissident OBGYN, but I'm an OBGYN nonetheless, all right? And so we have indicators, things like marital status, things like if your pregnancy intention. So those are indicators, things that we measure. So in tech, y'all have indicators. But what framework were you using to create these indicators? How do you pick indicators based upon equity? How do you pick indicators that's looking for justice? Especially when we understand that when we have social determinants of health, you have things like housing, food insecurity, transportation, that cause us to have inequities in our diseases, right? So children are obese not because they just like Chewies, right? We have childhood obesity in this country because we have lack of access to food, and we have to healthy foods. We have not safe neighborhoods to play in, so that causes inequities. But you see the top of my slide is still very empty, because what we haven't had a conversation about is this power and wealth imbalance. And those are things like our labor markets, things like our housing policies, and all the other structures above that. And there are 3 main root causes in the US context for those. And those are racism, classism, and gender oppression. So you can build tools that make these 3 things worse. You can not address racism, and so therefore your tools will then cause Black people to have worse outcomes in their maternal and child health outcomes. So I'm begging you all, as smart, amazing people as you are, to be aware of those facts, that the power and the choices that you make creating tools can cause harm. So you need to be aware of that. So although the social terms are really important, how you interact with those and what tools you put in place, if you only do housing policy, if you say I'm gonna have a tool where everybody can get free Ubers without fixing transportation access in the entire country, we'll just have a bunch of Ubers running around, and we haven't gotten actually to having train access to people who live in rural America, where I grew up. So race is not genetic. I hope y'all know that. I love being Black, I'm gonna die Black. We finished the Human Genome Project, so when we have inequities based upon race, they're not because of people's genes or their choices. They're because of policies that we've created. So the good news is that we all, can make different choices when we create our things. So it's important that framing, when you think about the future, is important. So we created the Campaign for Black Babies. We interviewed Black women across the country who had an infant death and said, what were some of the things that were barriers? And a lot of them talked about not having access to information. And what do you all have? A lot of information, and it's not connected. People don't have their own medical records. People don't have access to their information about their health. You can democratize data today. You can decide today that it's important that actual people have information that they need to live. And we're also creating a patient-reported experience measure with the American College of OBGYN, where we're asking women, what would respectful care look like? How would it feel to be treated, valued in your care? And then putting that into a measure that they can use in a tool inside of hospitals to hold hospitals accountable for how they treat patients. So that's really important. And then lastly, I just want to say I'm a part of the founding advisory board of the Black Mamas Matter Alliance. And we need you all. We have about 50 organizations across the country doing work on the ground, but we need the technology and the tools to really amplify that voice, to really amplify those tools, or we're not going to be able to make change, because we're all in this together. That's it.
Thank you. Joia, thank you for setting the stage so brilliantly there. I want to come back to a point you made when we were talking earlier about when you're on the ground educating providers, folks that are at the front line of patient care. You said a lot of the things that people are doing today, they think are clinical guidelines that they're supposed to follow, but they're not.
Exactly.
They're just
they're just habit. One of the examples, we were working with a community in Michigan, and they were telling patients that they had to wait until they were 8 weeks pregnant to come in for their first appointment. Now that assumes a lot. If someone calls and says, hey, I think I'm pregnant, and the person at the end of the phone says, are you 8 weeks? And they say, I don't know, or I'm not sure, and they say, well, call back when you are. right? So that assumes, A, we teach sex education in this country, which we don't, right? So that starts off top. So people don't know what even 8 weeks mean. And then we are creating a barrier to access. Right. We are not giving people the information that they need. So there's so much opportunity because when we work with that community, and they really believe that that was some kind of standard. It made me even call the American College of OBGYN and say, look, I've been paying dues for a long time, I trained. Are we supposed to wait till 8 weeks? They're like, no. It became a cultural norm that became then embedded in how they provided care, which created a barrier. So once they stopped doing that as a cultural norm in the community, they increased the number of patients who were seen in the first trimester. Before then, they had been blaming the patients, right? Patients don't want to come. They don't like coming to the doctor. They come so late. Mm-hmm. Not even acknowledging the barriers that we create for people in our own norms and our own beliefs.
Mm-hmm. And I'd love to also for you to share some other on-the-ground experience with your training mm-hmm. where you have seen a shift. So yes. Is there a time that you can point us to where you did go in and then you sort of helped facilitate a change, especially in that respectful communication? Yeah. I'd love you to share some of that.
Yeah, so we are at a moment, especially right now in this country, that I do people think, especially as for providers, we understand that medicine is not transactional, right? It's not, I can just give you a pill and you'll go off and that'll fix all your life, right? So much of it requires us to actually listen, and people come with their own information, their own story. So we've experienced across the country, cities, hospital systems that we work with, city and state health departments that are really embedded in this idea of listening and co-creating and having shared decision-making with their patients. And they need decision-making tools from technology to help to do that. They need information, but there is a cultural shift from this, I am the provider and I should tell you and you should just go off to listen, to versus we are doing this together. I need you to really be my partner in your healthcare because I come with my own information as a patient and I come with my own lived experiences that you don't know everything about me. You might have assumptions based upon what you think I'm gonna do or behave and how I'm gonna interact, but really talking to me and listening to me is so important.
So you queued up the technology solutions, yes. which is a perfect introduction to our next presenter, Melissa Hanna. If you come on out as I introduce you. So Melissa is the CEO and co-founder of Mahmee, a prenatal and postpartum care management platform that looks to increase positive health outcomes for moms and babies. Melissa founded Mahmee with her mother in 2014 when they saw the disconnect between large health providers and the networks of independent, non-physician maternity care professionals like nutritionists or lactation specialists. As of yesterday, this just happened, she was named one of Inc. magazine's 100 Women Building America's Most Innovative and Ambitious Businesses.
Woo-hoo.
Today, she's here to show us the Mahmee platform and how it links mother and child's health records, flags alerts, and helps keep the care team coordinated.
You need this or no?
No, that's fine. Thank you. Thank you so much. Thanks for the introduction. So I'm Melissa Hanna, co-founder and CEO of Mahmee. And I'm going to tell a little bit about what the Mahmee platform does and demonstrate how it works. So we are a comprehensive care management platform. We partner with payers and health systems to introduce new models of value-based care, which has been notoriously difficult to do in the field of maternal and infant health. We're making it possible for preventative and proactive support to become the standard of care for every mother and baby dyad. The demonstration that I'm about to present is a real clinical workflow and a true story that happened in the platform several months back between one of the moms in the community and one of the Mahmee care managers, who we call coaches. So we're looking at a mom's dashboard. This is Trisha. She's 5 days postpartum, and she's got some care directives around breastfeeding, some recommended articles, and she can also track her baby's weight right from the dashboard. So she's going to do that now and log a new weight for Wesley today. At 5 days old, he is 5 pounds and it's going to be 4 ounces. He is premature. And he's losing weight, but this is still normal within the first 1 to 2 weeks of life. So we're logging that, and she's also in conversation right now with a coach on the platform, specifically around breastfeeding support. Megan Jackson, the coach, had reached out to her proactively to ask how things were going on day 5, knowing that she's exclusively breastfeeding. She'd mentioned she was having some questions about latching and positioning, so Megan sent an article over through the Mahmee Guide so that she'd have access to very specific and very targeted advice around the thing that she was challenged with. But she's now responding back with some other information, that her left hand and her left foot are shaking uncontrollably, and it's making it hard for her to hold the baby, and she's not really sure if this is just muscle exhaustion or something else. Looking at Megan's dashboard now, she's logged in for the day, and on her dashboard she has recent appointments that she's, the patients that she's seen recently over video call, and she also has a shared list of additional care needed patients. That's a list of flagged rising risk mothers and babies in the platform. She's checking her messages now and seeing the conversation with Tricia, where Tricia has now introduced a new symptom, a new concern that, as far as Tricia's concerned, is just a problem because it's making it hard for her to breastfeed her 5-day-old. But our practitioner, Megan, who is a lactation consultant, is going to look up her medical record here, where we've created a dyadic medical chart syncing mom and baby's information together so that she can see medical history, pregnancy information, and specific birth history information from baby Wesley. And now we're starting to get some more clues. We're seeing that there were some antepartum conditions, that Wesley was born a few weeks early, and that Tricia went into labor early and pushed, and a vacuum was needed because of a complicated vaginal delivery. There was some bleeding and some vaginal cuts and tears as well. So we've got the clues about tremors and shaking on the left side of her body, and we know that this was a complicated vaginal delivery. We see that she's got a pretty robust care team. She's got a pediatrician, an OB, a doula, and a midwife, and mommies on her care team. We're going to call Tricia. That's the next step in this clinical workflow, since she has represented some concerning symptoms. So we're going to document that interaction, and we found that this started on day 4 postpartum. So it's been logged there. The next step is going to be to contact the OBGYN. In this case, our clinical standards would say this needs to be escalated to the OB's attention immediately. We got on the phone with the OB, and we relayed those symptoms. The OB confirmed a concern about septic shock and said, you know what, let's meet her at the, urgent care. This is not a clinic visit. And so we then were prompted to facilitate the getting the patient to urgent care. We also are flagging this patient within the platform so that all of our on-call coaches are made aware on that additional care needed list that Tricia needs additional monitoring at this point. So we facilitated an urgent care visit. We've tracked that she's escalated in risk. And we're going to do one final thing. We're going to contact her pediatrician through the platform, who's linked here, Dr. Burgess, to make sure that the pediatrician is aware that the feeding plan and care plan for this premature 5-day-old may now be impacted once we figure out what the final clinical diagnosis is for Tricia when she gets to urgent care. And so that's what's being provided here as information for the pediatrician. It's a different protocol because the pediatrician is responsible for the infant, whereas the OB is responsible for the mom. So a call goes to the OB, notice goes to the pediatrician. The end of the story is that Tricia was diagnosed with borderline septic shock, and that the vaginal tearing, which seemed minor at the time that she was discharged from the hospital, and everything else was a good, clean bill of health for her and baby, turned out to be the beginning of an infection. She had some pretty serious uterine tearing, and by day 4 postpartum, she was experiencing septic symptoms. The infection had hit her spinal cord and was causing the left side of her body to tremor. Mommy was the first care provider on her team that she expressed these symptoms to, and it was not because she thought that she was experiencing a life-threatening medical concern. She just wanted breastfeeding help. So when we think about where postpartum care, as an example, fits into the overall clinical workflow and what's possible when you're providing ongoing proactive support on topics that are relevant to patients but may not present as clinical crisis moments, you have an opportunity to really introduce some impactful patient interventions. That's what happened here. Tricia was held overnight in the hospital for 3 courses of antibiotics. Her partner cared for the baby, and we adjusted the care plan to include formula and pumped milk for the next 24 hours. Once she was discharged, she began to recover, and the physician told us 2 days later, after another checkup with her, that this facilitation prevented a hysterectomy from occurring.
Thank you so much. Yeah. So, and that's not the only sort of life-saving scenario that Mahmee has intervened in. You shared a story around postpartum depression as well.
Absolutely.
Yeah.
The context of this kind of communication with patients, which is designed to be a trusting, ongoing relationship that lasts as long as the patient wants it to. We can work with patients up till the baby's first year of life. This dynamic means that moms will express things to us that they may not feel comfortable expressing to their physician, or may not even have a dedicated primary care provider to share this information with. And in many cases, we've been the first line of defense against postpartum depression becoming postpartum psychosis. We've intervened on multiple cases of suicidal patients.
Yeah. So I would love to get your thoughts, Melissa, before we wrap up this segment, on how this has changed the dynamic on the care team. Have you been seeing just evidence of more collaboration now that this platform is cueing people in to these ways of connecting to each other?
Absolutely. Historically, providers that offer ancillary care, like lactation services, doula support, midwifery, or childbirth education, have been left out of the equation on these sort of clinical workflows. The work that we're doing with health systems and distributing access to Mahmee through these partnerships and through these med groups means that a lot of this is physician education as well. We're working alongside the physicians to make it possible for these connections to occur so that communication and collaboration happens naturally in these relationships. It's something that everyone's always wanted, but the technology has not been there for this to happen before, and the mindset has unfortunately been one of, they're out of network, they're outside of the building, we don't have access to them. And so we hear those sorts of complaints from physicians, and we also hear the desire to connect. And so we're facilitating that through these sort of launches across the country.
So Joia, I would love a question from you or a comment from you. You know, where do you hope this goes? Like, what is your dream for this?
This is pretty exciting. I mean, I'm so impressed. So I want to thank you for, and really embedding it in what people actually need, and not creating kind of technology without listening to what the patient, so spending the time that you did listening and following and seeing where the need is. And so the desire, it could, bridging the gap between, a lot of physicians feel like with this new conversation around social determinants of health, right? You saw that slide I put up there. How am I going to fix poverty, and how do I know what happens with sepsis at home and I'm not there? This technology allows you to bridge that gap. It's not that we're expecting hospitals and providers to magically become anti-poverty fighters, right? But they do need to know what's available and what's happening with the patient when they're at home and what they need when they're not there. So the beauty of having an actual technology, a platform where you can reach across, is you can bridge that and have a connection. Many of the places that we go, the hospitals and the providers and the systems don't even know what's in their community. So this allows that to occur. So thank you so much.
I know this is an early part of your journey, so we wish you the best of luck, and thank you for all the work you're doing on the ground, and a round of applause to all of them. Thank you. Okay, so our next topic that we're going to be looking at is the one of human trafficking that I introduced up top. Setting the stage for us is somebody who's really sort of leading the cause of how the healthcare system needs to pay attention to this issue. So I'd like to welcome out Hanni Stoklosa. Come on out, Hanni, as I introduce you. Hanni is an emergency physician at Brigham and Women's Hospital with appointments at Harvard Medical School and the Harvard Humanitarian Initiative. And she's the executive director of HEAL Trafficking, an internationally recognized expert advocate, researcher, and speaker on the well-being of trafficking survivors in the U.S. and internationally through a public health lens. She's advised the UN, the U.S. Department of Health and Human Services, Labor and State, and more on issues of human trafficking, and testified as an expert witness multiple times before the U.S. Congress. Today, she's here to share with us the scope of human trafficking in the United States, as well as how HEAL is approaching the issues from a public health perspective. Thanks so much, Hanni, for being here.
Thank you. Good afternoon, everyone.
Good afternoon.
Good afternoon. Thank you. I'm a pastor's kid, so I'm used to this call and response. I'm not from New Orleans, but thank you for entertaining me. I am really honored to be able to talk today about the role that healthcare can play in combating trafficking, and I'm followed by two excellent other panelists. Backstage, we dubbed ourselves H-cubed, so we have Holly, Hanna, and Hanni, and we're all going to be talking about this really important issue. I'm going to start off by giving you my own personal journey to creating a movement in combating trafficking within healthcare. I was going to start off with a baby picture, but this is my baby doctor picture. So, you know, as I mentioned, I'm a pastor's kid, and I grew up knowing that my life was to serve others, and that's where ultimate meaning came from. And so medicine was a really natural choice for me as I was considering different careers. But I didn't just choose medicine in order to be able to impact individuals. I very intentionally knew that I wanted to be a doctor that was an advocate, that was creating macro-level change, that was changing population health. And so all along the path of my training, I had that in the back of my mind and was very intentionally working on building those tools in my toolbox so that I could be a successful advocate as well as a quality clinician for my patients. And that led me, in particular, as a career within medicine, to emergency medicine. I love emergency medicine. I get to take care of patients on the worst days of their lives. It is such an honor and privilege. I get to take care of a CEO next to a homeless person that's dealing with alcoholism. We truly are the safety net within healthcare. And here I found myself as a Harvard-trained, Harvard emergency medicine doctor. And going back to that sort of mission-driven life, what was I here on earth for? What was the unique thing that now Dr. Hanni was on earth to do? And just around that time, this important study came out that 68% of trafficking victims in the United States access health care at some point during their exploitation. This study covered labor and sex trafficking survivors. And when I read this study and read this data, I knew that this was the issue that I needed to work on, and I was just flabbergasted because I reflected back on the patients that I had cared for while I was going through my training and realized how many potential victims, how many vulnerable patients, and probably some trafficked individuals that I had missed. Did I miss Juan? He was a construction worker from Honduras, had come in with a routine injury that I knew how to care for in a high-quality medical way. But I had remembered that he was malnourished and that he had bruises that didn't make sense in terms of his injury, but I didn't know what kind of questions to ask to explore these alarm bells that were going off in my mind. Or what about Marco, a transgender, two-spirit Native American who came in after a heroin overdose? And I remember the man that just sort of like came in and swooped and took her out of the emergency department that seemed to be controlling her life. But I didn't have the skills, I didn't have the knowledge in order to be able to respond. And if I was in this position as a Harvard-trained emergency medicine physician, how many other clinicians in the United States, whether they're nurses or doctors or physician assistants or nurse practitioners, also were in the same boat? I knew that this was the issue that I needed to dedicate my life to, and I also knew that I couldn't do it alone. So out of this, we created Heal Trafficking back in the fall of 2013. So it's now been about 6 years. We're now a network in 35 countries of survivors and multidisciplinary professionals that are fighting trafficking from a public health lens. We work on research, education and training, advocacy, direct services, and we do it as a unified group. As I mentioned, we have that public health approach. We believe that you cannot prosecute, arrest your way out of trafficking. And also from a healthcare perspective, it's not enough just to be treating the downstream health consequences of trafficking, but we need to look upstream. And what is the role of healthcare in preventing trafficking from happening in the first place? We've heard from some excellent speakers that have addressed health equity issues of social determinants of health. These are all upstream from trafficking. What is the role of healthcare in preventing trafficking from happening in the first place? As on my own journey of understanding trafficking and understanding how we as healthcare can better respond, one of the things I've been surprised by is how, even with my excellent training, I've realized that for most of our patients who have experienced violence that come through our doors, we have inadequate tools, and we've also been trained incorrectly. The majority of our patients have experienced some sort of violence, whether that's child abuse, whether that's domestic violence, whether that's sexual assault, or whether that's human trafficking. What can we do better to take care of each of those patients who come through our doors? So the challenge I have for all of you in the technology space is to think not just about trafficking, sort of the tip of the iceberg, but how can we do better in caring for that whole spectrum of violence that our patients may have experienced? Thank you.
Thank you. Thanks so much. So, Hanni, I wanted to ask you about something that you said that was so important, and I think it applies to both the clinical lens as well as the technology developer's perspective here, and that is this role of unconscious bias. I'd love you to talk about how you think about that term and the ways in which we can address it.
Yeah, so first of all, as I was thinking about what are the best ways that we need to train clinicians, I realized that doctors are human, first of all, and that we come with our own assumptions around even what a perfect victim might look like. So in our minds, that perfect victim has a race, has a gender, has an attitude. And we also know when we look at the ways that media portrays what trafficking looks like, that also has a race, a gender, and an attitude or a behavior. And that when we talk to trafficking survivors, that there's such a diversity from there that if we use our sort of natural heuristics to think about, okay, this patient is somebody I'd worry about trafficking for, that we're going to be missing entire populations. So for example, media portrays trafficking primarily as sex trafficking, but we know internationally that labor trafficking is more common. Rarely do we think of males as victims, whether we're talking about domestic violence or we're talking about trafficking. And so we need to actively and proactively make sure that as we're training clinicians on trafficking and other forms of violence, that they're addressing their unconscious biases, or we're going to be missing all of these populations.
And even in terms of thinking about this as screening versus another word, I think you want to kind of change the conversation even in terms of that clinical interaction. Can you speak a little to that?
Yeah, so this has been a wake-up call for me as a clinician. When we think about screening, there's this natural instinct to go into your medical mode of screening. So we screen for a lot of things really well, especially in emergency medicine, but we have all these evidence-based tools to, with a fair degree of certainty, know whether somebody has a blood clot or a heart attack. It can go on and on. And when you use the word screening to talk about detecting forms of violence, it puts people in that sort of medical mode. But what we know, as I've looked at the literature from domestic violence, as well as the emerging literature in human trafficking, is that it's more about an approach that builds trust that we need to engage with our patients in, as opposed to like a checkbox where we're going down a list of validated questions. That a patient is much more likely to disclose to you what's happening if you're at eye level, if you're treating them with kindness, if you're talking to them in a private place. And all of these things are lost when we use the word screening. So I've come to use the word assessment in talking about how to best approach trafficking victims.
Agreed, and also that it applies well beyond this one really important issue as well. So I actually think that cues up Holly's presentation really well. Holly Gibbs, I'd like to invite you out here as I introduce you, Holly, is the director of Dignity Health's Human Trafficking Response Program, where she oversees efforts to educate staff about various forms of violence, including human trafficking, and how to support victims and survivors using a trauma-informed approach. As a survivor of child sex trafficking herself, Holly has testified before Congress and consulted for numerous organizations. Today, she will share with us how a health system has responded and taken action on the issue, and she'll share some specific tools that are also being used. Welcome, Holly.
Thank you, Indu. Dignity Health launched its Human Trafficking Response Program in 2014. So I came on board in 2015, and I'd like to show our website that offers some of our key resources and some background information about our program. So again, we launched in 2014. The goal was to educate healthcare staff on how to identify patients who are at high risk of labor or sex trafficking, and how to educate and offer assistance or intervention support and services in a way that's trauma-informed. There are two key dimensions to our program that I want to share. One is that everything that we do, we try to do from a trauma-informed approach. All the materials, all the procedures, the policies, and so on, we're striving to be trauma-informed. And to be trauma-informed, we actively collaborate with survivors of labor and sex trafficking across the country to inform our efforts. And our program is survivor-led. So Wendy Barnes, who is the HT program coordinator, and I are both survivors of human trafficking. I was trafficked when I was 14 years old. So this is going back to 1992 in a small town in South Jersey where I met a man at my local shopping mall who convinced me to run away from home with promises of helping me become a musician or a model or something glamorous in Los Angeles. I was a young, vulnerable teenage girl. I had just graduated 8th grade middle school, and I was very fearful of going into high school. I was afraid I was going to get beat up in the hallways, in the bathrooms. I thought that my friends were going to leave me behind. I felt like the end of the world was on the horizon with the beginning of high school. And so this man took advantage of that, and he offered me an opportunity to run away. And not only did I think this was a real opportunity, I thought this was my only opportunity. This was my once-in-a-lifetime opportunity to escape this little town in South Jersey. In reality, what this man did was he forced me into prostitution. I was arrested within the same week, in the middle of the night, on Pacific Avenue by a very mean police officer. He arrested me, handcuffed me, put me in the back of a cop car, and on the way to the police station, he called me the worst names that you can think of to call someone in a situation like that. So I think that what he was trying to do was take he was like trying to scare me straight, but what he actually did was he traumatized me. He planted a seed inside of me that made me believe for years afterwards that I was fundamentally damaged and I no longer belonged in society. There were 3 police agencies involved in my case. Once this man got to the police station and he ran my name, he determined that I was a missing person. So in the end, detectives got involved, and there were 3 police districts involved in my case. And the man who convinced me to run away from home, my trafficker, he was caught and convicted. But it took me years to overcome what happened to me. And this is why I'm so passionate about this program at Dignity Health, because in my experience, I had to go through an emergency department, I had to be assessed by an emergency psychiatrist, an OBGYN physician, and I was ultimately placed in a mental health facility. All of these healthcare encounters away from law enforcement were all opportunities to educate me and to offer me support and services. I didn't get that. All of the efforts in my case were focused on who this man was, finding him, tracking him down, and prosecuting him. I think I was lost in the mix. And what we're trying to do at Dignity Health is make the patient front and center, to empower the patient to make his or her own choices about where they want to be connected. So one of the key tools that we developed at Dignity Health in partnership with Heal Trafficking is the PAIR tool. So we have a new policy called Abuse, Neglect, and Violence, and a key component to our policy is this procedure, the PAIR tool. PAIR stands for Provide Privacy, Educate, Ask, Respect, and Respond. And so this approach is a universal education approach to screening, as opposed to asking questions to lead to a disclosure that will then lead to an intervention. We're wanting to educate patients and then offer them an opportunity to speak with an agency in a private setting. There are several other resources available on our website, and I'll point out just a few. We have a shared learnings manual where we describe our program in detail, including program structure, and we have a link here to our Human Trafficking 101 module, which dispels 10 common myths associated with human trafficking for healthcare professionals. And another key resource that we have available, if I can pull it up. So we have a set of posters, victim outreach posters, and I may need help getting to that link, but these victim outreach posters were designed by survivors of labor and sex trafficking. There you go. So this is one, you can be in control of your life, designed by survivors of labor and sex trafficking, so the imagery and the language are all survivor-informed. And these are all available on our website, and you can contact me for additional resources.
Thank you so much, Holly. I heard that the two of you met in person for the first time. Is that recently? Because you guys have been collaborating on the phone and email a lot. You've met before.
I've been lucky enough to work with Heal Trafficking and the founders, Hanni Stoklosa and Susie Baldwin, for a few years now.
Yeah.
So no, we
But we
cross
rarely get to
paths.
co-present together,
Right,
which is
yeah.
really, really, really nice. We're always like sleeves rolled up working on projects, so this is a nice treat.
That's really great. I'd love you to talk a little bit about that collaboration now as you take this work to health systems around the country. What is that rollout going like? What are maybe some positive stories you're encountering? What are some challenges still out there?
So when we launched our program at Dignity Health, going back to 2014, there weren't a lot of resources available to us. I didn't have a policy or a procedure to start off with, or even a program structure to get started with. So for any healthcare system represented here, if you want to begin some kind of a program to address human trafficking among your patients, there are lots of resources and lots of organizations out there, especially Heal Trafficking, which is a national, international organization bringing together health professionals and sharing all kinds of resources.
I wonder if you could share with the PAIR tool how that conversation might go with a patient.
Oh, sure. Let me see if I can bring that up. So the PAIR tool is meant to be a conversation with a patient that you think may be at high risk of any type of violence. This tool is not specific to human trafficking. So the key steps are to provide a private setting, which would include explaining limits to confidentiality, educate the person about whatever types of violence you're concerned with, and do it in a way that's normalizing the conversation. Hey, I talk to all of my patients about sexual violence, domestic violence. I'd like to talk to you about this type of violence as well. And you'll see in the tool there's all kinds of example statements provided that you can use with your patients. And then if you're still concerned, like if the person is showing a high number of risk factors or some kind of indicators of victimization, then you want to ask about safety concerns and offer to assist them in connecting with local agencies. And if there are no local agencies available, the PAIR tool offers not only an overview of risk factors and indicators on page 2, but it also offers national hotlines on page 3 and space for you to enter your own local agency information. And then the final step is to respect and respond, regardless of how your patient responds. If they disclose victimization, if they accept assistance, you want to meet them where they're at and respect their wishes and then respond accordingly. And of course, that includes mandated reporting.
It's a real shift to not making it all about disclosure, rescue. Those are not the goals. The goal is to create that open door. That's why this tool is so powerful.
How is the response among other health systems going? Is this problem readily acknowledged? Do you deal with kind of denial, like this can't be happening in my community?
Well, we're seeing that we're really creating this movement. So some states have even mandated that health professionals have training on trafficking as part of their relicensure program. New York State was really pioneering and took it to the next step and requires that all of their health systems have protocols in place, which just makes so much sense. You don't want to diagnose something for which you don't have a plan. People won't even open that Pandora's box. And some health systems like Dignity Health with Holly's leadership are really leading the way. But we need to do more. Most health systems in the United States, I would say, don't have this on their radar and have not protocolized or operationalized response in the way that's necessary for us to really care for victims when they come through our doors.
And just to remind people, it's happening in every single state. We have documentation in every single state.
Right.
So we're going to now invite, so thank you so much, Holly, for presenting today.
Sure.
And we have one more presenter on this segment. I'd like to invite up Hanna Darton to the podium. Hanna Darton is the Program Manager of Ethics, Technology, and Human Rights at Business for Social Responsibility, where she works with multinational companies to align business and human rights strategies and facilitate the incorporation of sustainable practices into business operations. She focuses on the intersection of human rights and new disruptive technology, and she leads the Tech Against Trafficking Collaborative Initiative, which we're going to hear about today. We're going to learn more about this initiative, and she's going to show us a few platforms and tools that the group has identified to address trafficking. Thank you.
Great, thank you so much. And I am the third H in this trifecta today. So you heard from Holly and Hanni already. So I'm Hanna. Lovely to meet you all. And thank you for having me. So as you've seen from the earlier presentations today, human trafficking and modern slavery are complex, thriving crimes that are happening across the world. According to recent estimates, approximately 40 million people are subjected to some form of modern-day slavery. Within this context, technology has the potential to serve as a powerful tool to disrupt and reduce modern slavery, prevent and identify crimes, and provide remedy mechanisms for victims and survivors. Tech Against Trafficking, the collaborative initiative that I help run at BSR, is a coalition of technology companies collaborating with global experts to help eradicate human trafficking. And it was launched in June of 2018 to really help advance and scale the use of these technologies around the world. So as you can see here, we have 7 member companies, including Amazon, BT, Microsoft, and Salesforce. And we work with a number of different advisors across the world to really help us run our coalition and provide that expertise and insight into our work. As a first step after our formation in 2018, we took on a landscape mapping. We wanted to better understand how technology is currently being used to fight human trafficking, what tools are out there, and what the gaps are. How can we make these really work better for the people that are using them? So we actually identified 305 tech tools, which is way more than we were expecting within this initial landscape analysis. And these are being deployed for a variety of different purposes that you can see here on the screen. Of these, the largest chunk was around victim and trafficker identification. So we actually saw over 90 tools doing almost exactly the same thing in identifying victims and identifying traffickers perpetrating these crimes. These technologies are being used around the world with a much heavier concentration in North America, Europe, and Asia that you can see here. They actually have a limited focus on industry-specific tools. So most are working cross-sector, and only about 1% are focused on healthcare and pharmaceutical services. Given the magnitude of the problem and the complexity in tackling it and identifying victims, as Hanni was explaining earlier, there's a need for expediency, increased stakeholder engagement, and collective effort at backing the right technologies at the right moment in time to maximize impact. So we at Tech Against Trafficking, after having conducted this landscape analysis, decided to really launch an accelerator program that would help advance and scale the work of these technology tools that are being used to combat human trafficking. Through the accelerator, we map the landscape of technologies, identify and select the tools that have the potential to scale, and we accelerate their solutions with the provision of resources and support from our member companies. So today what I'd like to do is actually show you 2 of those tools, 2 of the 305, and talk a little bit about how they're being used. So we'll move over to this screen. So the first tool is the Counter-Trafficking Data Collaborative, or CTDC, which is actually the first participating organization in the Tech Against Trafficking Accelerator program. CTDC is an initiative of the International Organization on Migration, or IOM, and it's a global human trafficking data hub that's publishing harmonized data from counter-trafficking organizations in every country around the world. The goal is really to reduce the barriers of information sharing and to provide a mechanism for organizations and service providers to get data to public and policy audiences so they can improve responses to this crime. So looking here, you can see that the Global Data Hub, CTDC, actually has over 90,000 individual cases in its database from 172 different cases of countries of exploitation. Their interactive map, which you'll see here in tab 2, allows you to dive into the details. So you can see where the exploitation is occurring if you click this box, or you can look at the countries of citizenship. Where are these victims actually coming from? If we click on the US here, we can see that there's actually over 24,000 cases of victims here in the US being exploited, primarily coming from China and Mexico. There's a large percent of females, 86%, most of whom have been sex trafficked and are between the ages of 9 to 17. So looking, we can really dig around these data, and these are only the cases that we have found. Those are that are being put into the database. There's so many more, as Hanni was saying, in labor trafficking that are hidden below the surface and we haven't yet been able to identify. If we continue on to the next tab, we also can look at what are called data stories. So exploitation of victims, the trends, the stories of what's actually occurring under the surface. This describes the exploitation types, allows you to click into specific data and look at what's happening in forced labor compared to sexual exploitation. What does victims of trafficking and sex trafficking versus labor trafficking look like over time? How do those compare? And further down, what are the relationships between a recruiter and a victim? How are these manifesting? And how can you, as healthcare providers, look at who's coming into your different facilities and offices and what might be potential red flags? We also can look at the means of control. Drugs were mentioned earlier, but there's restrictions to medical care is often a means of control as well, along with others. Here we can also dig into industry-specific deep dives that allow us to see what's happening in the hospitality sector. How is human trafficking manifesting in this area? And this is only one of many stories that you can explore on this database. There's one out that's coming out in healthcare soon, so I'd encourage you all to take a look and be able to really dive into the details here, look at the age and gender breakdowns, as well as how the control aspects are really taking place in this field. Moving on, we wanted to show you one more app, which is the Stop app. This is an app that was created by Stop the Traffic to help individuals around the US and Europe, primarily for this app, be able to report incidences of human trafficking. So you can download this on your phone, and the app itself, as you see here, will provide you some ways in which to spot signs of human trafficking, either sex trafficking or labor trafficking, and it's a very simple interface that allows you then to just report an incident and files it with a local law enforcement and healthcare professionals in the area, as well as local responders that have been trained on dealing with these instances. So I highly recommend taking a look at this as well. And these are one of, as I said, 305 that we've identified. There's probably many more out there as well that are helping individuals from every industry take part in really combating human trafficking and helping us figure out exactly what the magnitude is so that we can enable better responses moving forward.
Thank you so much. All right. Well, unfortunately, we're out of time, but Hanna, I really want to thank you for opening our eyes to sort of what employers and what the business community is doing, and to Hanni for really leading us in this conversation around what healthcare organizations can do to respond. So I just want to thank you both and my whole panel so far for giving us the third edition of the Unacceptables at Health 2.0. Thank you so much.